So let's introduce our speaker. As I said, you might recognize her, but I will give her another introduction and then I'll pass it over to her for the remainder of our time together. So Dr. Jeanette Crenshaw is a professor at Texas Tech University Health Sciences Center School of Nursing in Lubbock, Texas, and teaches in the Doctor of Nursing Practice program. She is a nurse, educator, and a researcher. Dr. Crenshaw earned a DNP in Executive Leadership in Nursing, an MSN in Administration and Management, a BSN in Nursing. Her professional work focuses on promoting evidence-based leadership, maternity, breastfeeding, and preoperative fasting practices. Throughout her career, she has been recognized for her expertise on healthy birth and breastfeeding practices and skin-to-skin care after birth. In her spare time, Dr. Crenshaw loves to dance and go for walks with her husband and spends lots of time with her 3 adult children and her 3 grandchildren. Please join me in welcoming Dr. Jeanette Crenshaw as she presents this webinar, Keys to Good Milk Production. Thank you for being with us, Jeanette. Really appreciate it.
Thank you so much. Can everyone hear me and see me? Yes? All right. So I'm going to share my screen, and Martha and Vanessa are, when I start sharing, I won't be able to see you anymore, which is really sad. But I have some visual aids I'm going to use, so your job is to tell me if you can't see them, because I can't see myself to tell if how they show. So I need your help with this. And so I'm going to start sharing my screen now. And I'm going to stop sharing because I wanted to click on share sound and optimize video clip. Okay, so now I'm going to share again. And I'm going to bring over the presentation. All right, so can you tell me if you can see this and if you can hear me okay?
We can see it. Yes, and we can hear you.
All right, so keys to good milk production. And so raise your hand so Vanessa and Martha can see if you were with me in September. So I have a sense of how many of you heard me last time. So what does it look like?
I think I'd say it looks like a majority of the people that I can see have their hands up.
Okay. That tells me that I'm going to go kind of quickly during the beginning, and we'll go a little slower when we get to content that isn't a review, because it's hard to talk about keys to good milk production without talking about what do you need to know before birth to make sure breastfeeding gets started right. So we're going to talk about it in the scope of prevention. There's so much that can be prevented when mothers know things prenatally to help breastfeeding get started right. And that was a bit of the focus of the last time I was with you. So that's why I'm going to go quickly through those slides and then you'll have them. So what do you think women need to know prenatally to get breastfeeding started right? You can put it in the chat or you can come off mute and just tell us what you think. And there's a myriad of things, so don't worry if you don't feel like you that there's no 5 right answers. So somebody come off mute or put it in the chat and Martha will tell us.
Can you ask the question one more time, please?
What do you think women need to know prenatally to prevent breastfeeding problems, to get breastfeeding started well?
That milk doesn't just come out the first day.
Okay.
Sometimes they're a little like not having any milk, and I'm telling them it's colostrum first.
Right, right. That colostrum is the primary source of nutrition the first few days. Good. What else?
I can read you a few from the chat. We've got some good stuff coming in. Not everyone has the same experiences. Babies'
Good.
tummies are really small at birth, so they don't need a lot of
Ah,
milk.
yep.
They need to know about the breast changes during pregnancy and
Hmm.
how to obtain a proper latch, feeding cues, breast development, how milk is produced.
Well, wow. I don't think we need this presentation. You guys are brilliant. You guys are brilliant. Yes, yes. So we're going to just go over just to reinforce it for everybody some things. We said this last time that your role is to help women choose to breastfeed, and then once you've done that, help women and their families get ready for breastfeeding. And everything you do with women should be to build confidence, whether you're seeing them prenatally, interpartum, or after the birth. And some of the things that you can do are to make sure that women take a prenatal childbirth and breastfeeding class. That can help women get ready. You can give them confidence building breastfeeding information. And that means you need to look at that information and say, does this build confidence? If I heard this, would I feel like I can do this? Not only that it's possible, but I can do this. And that's what we mean by confidence building breastfeeding information. And think about the words we say, because we want to avoid subtle messages that might discourage breastfeeding, make breastfeeding seem complicated or really hard to do, that you need the secret key to unlock the chain to make breastfeeding work well. Well, you don't. We just need to help avoid the subtle messages that discourage breastfeeding and make breastfeeding seem complicated. Use breastfeeding imagery. Lots of pictures of breastfeeding everywhere. Images of breastfeeding, not just in your bedroom in gorgeous lingerie, but in everyday life. Use imagery exercises, and maybe another time we can talk about what ideas we have for imagery exercises. This is your opportunity to dispel myths, things that just are not true, and then give realistic images of newborn behavior. So, for example, a myth might be good babies sleep through the night. That is a myth. Babies' needs can be scheduled. That is a myth. We cannot schedule a baby's needs. And then replace those myths with realistic images of newborn behavior. Newborns breastfeed a minimum of 9 to 12 times or more per day, and they nurse frequently at night. In fact, babies are nocturnal, and they cluster feed. So a mother knows in advance that, oh, I just breastfed you an hour and a half ago. How could you be hungry again? Well, babies cluster feed, so this is normal. And also that babies calm quickly when they're skin to skin with mama. So knowing that that is a way of helping their baby calm down and be prepared for breastfeeding. Also, figuring out what it is for this particular mother that might get in the way of her choosing to breastfeed. And the best way I have found to do this is to have them answer the question, I would like to breastfeed my baby, but what is the reason that might get in the way? And you could do this anonymously if you have a group situation, or you can do it individually. And you can do it with partners, whether it's the father of the baby or another partner. I would like her to breastfeed, but keeping childbirth simple. We talked about the 6 healthy birth practices the last time I was with you, but remembering that you want to let labor begin on its own, walk, move around, and change position throughout labor. Bring a loved one, a friend, or a doula for continuous support. Avoid interventions that are not medically necessary. The more interventions that occur, the more likely that that baby is not going to be ready to breastfeed at birth. Avoid giving, or be skin to skin at birth. Avoid giving birth on your back and follow your body's urges to push, and keep mamas and babies together. It's best for mother, baby, and breastfeeding. The last time I was with you, we talked the entire time about skin to skin care, but mothers need to know in advance how important skin to skin care is, that it awakens breastfeeding reflexes and promotes physiological adjustment to a baby being outside the uterus, and promotes maternal infant bonding, just to name a few of the myriad of things we know about skin to skin. In fact, skin to skin is so important that we could call it the keystone to improving breastfeeding outcomes. And a keystone is the most important stone in the arch of a bridge. Without this stone, the arch would collapse. The keystone holds the arch together, and I would say skin to skin care is what holds breastfeeding, makes breastfeeding go well. So thinking of making sure all mothers know about skin to skin care, not only as a prevention strategy, but also as a strategy to fix issues that are problems with breastfeeding. And of course, skin to skin care leads to a secure attachment. And all mammals do it. One of you mentioned making sure that mothers know the size of an infant's stomach. And I like this visual aid from where you can say, tell me if you can see this, because I can't see myself. Can you see this?
Yes, the little ping pong that you're holding.
Well, this is called a shooter marble.
Oh,
And it's the size of a newborn on day one. And it the stomach holds about 5 to 7 ml. And then this is the ping pong ball, and it holds less than 30 ml, or less than an ounce. And that's about the size of a newborn stomach day 3. And then this is a extra large chicken egg. It holds a little less than 3 ounces, like 2 to 3 ounces, 60 to 81 ml. And then what do you think this represents? It's not on my picture. This is a soft baseball, by the way. What do you think it represents? Any ideas?
I got a guess in the chat for adult tummy.
Adult tummy, yes, yes. Bravo, kudos to you. Yes, and I think the thing that you can demonstrate with this is the fact that I think if I ask for a show of hands, how many of you have eaten more than this quantity of what appears to be this quantity of food in one sitting? I sure have. And that shows that we can stretch our tummies. And that shows that if we force feed or formula feed a newborn with several ounces of formula, we can make that newborn eat more than his tummy is really meant to eat. And helping mothers see, this is all my baby needs. Oh my goodness, look, that's about all the colostrum my baby's going to get per feeding. I have the perfect amount of food for my newborn. Then I have the perfect amount of food for my 3-day-old. Then I have the perfect amount of food for my 10-day-old. So that's a great way of helping mothers to prepare for breastfeeding, to not be worried that they don't have enough milk as soon as their baby is born. And I noticed you all mentioned feeding cues. Mothers need to know how to know when their babies are ready to eat. And this information you can tell mothers prenatally, or you could tell them if you see them in the hospital, or you can tell them if you see them after discharge. Feeding cues is a very important way to make sure that mothers have enough milk. And emphasizing the fact that crying is a late feeding cue. So, early feeding cues, I'll just mention a few of these because I believe you know all these. Baby's eyes moving under the closed eyelids. A baby licking his lips or making smacking noises or sucking on his hand. And helping mothers recognize, oh, if I see these early feeding cues, I'm going to pick my newborn up and I'm going to offer the breast. I don't need to wait for a later feeding cue. Active feeding cues are when the baby's they're not as subtle. The baby's actually turning his head and opening his mouth and actually attempting to attach to the breast. Can you all see that I'm holding a baby to my breast?
It's a little bit at the bottom of your screen. Yeah, that's a little better.
Let me.
Perfect.
Okay. Or a fidgeting and squirming, or the baby bobbing his head, or stepping movements, the early movements that a baby makes with his feet. And if a mother has not recognized those early or active feeding cues, the baby's going to be fussing, agitated, turning red, and crying. It is not possible to get a baby latched onto the breast when they're crying. Their tongue is at the top of the roof of their mouth, and it's actually necessary at this point to calm babies before offering the breast. And of course, the best way is by providing skin to skin care. That helps to calm a baby very, very often. But it's really important that moms recognize early feeding cues. And the average baby will give about 20 minutes of feeding cues before they're into late feeding cues. So if a mom can catch a baby early feeding cues, and of course, since moms are recommended to sleep in the same room with their baby, it's a lot easier for them to recognize those early feeding cues because their sleep gets in synchrony with their baby, and they become more alert as their baby becomes alert. The other thing that is a good conversation to have to help mothers be successful with breastfeeding is to talk about the fact that women can successfully combine work and breastfeeding, and that they don't need to figure that out prenatally. They can begin to sort that out a couple weeks before they go back to work, assuming that they let their employer know that they plan to combine work and breastfeeding. And we now have laws in place that came with the Affordable Care Act that enable mothers to have the right to provide breast milk for their baby once they go back to work. So now we're going to move into 4 keys to good milk production. And we may find that there's topics here that you'll tell Martha that you'd like a deeper dive into that we could do at a future time. But we're going to give an overview right now of 4 keys to good milk production. So the first is making sure that mom has sufficient glandular tissue. And this is typically something that would be addressed in a prenatal visit. And I'm going to share some slides now that are copyrighted and may not be reproduced, but I do have permission to use. So these are underdeveloped breast tissue, or the clinical name for it would be hypoplasia. And this mother was unable to provide breast milk for her baby. Now, this is another example of a mother who does not have fully developed breast tissue. In fact, she has marked asymmetry. One breast looks significantly different than the other, but she had a normal milk supply. So it's important to recognize that we can't always tell by looking. And so for a mother that may be at risk for not supplying a full milk supply, we would want her to start, but we would want her to have really strong lactation support to make sure that there's somebody that is assessing her newborn to be sure that milk transfer is taking place. Because again, this mother here was not able to provide breast milk. This mother had a normal milk supply. So this mother had impaired milk supply, so she was able to provide some breast milk, but not fully breastfeed her baby. So again, number one is making sure that mother has sufficient glandular tissue. The next thing, number two, is making sure that mom has intact nerve pathways and ducts. And in a environment where breast implants are normal, where women have had breast surgery, it's a very important question to discuss. And the intercostal nerve, which is right under her arm, and the other intercostal nerve that is a little lower down, those are nerves that if they've been damaged, it's very possible that she has an impaired ability to make milk. And so I'll move to this picture. It just shows the different nerve pathways, which I'm not asking you to understand each of these. But the thing that you can see is when you look at this areola, this woman also has nipple damage, which probably is secondary to the fact that she has an incision around her areola, that this woman had impaired breastfeeding because of the incision around her areola. Now, just like with breast asymmetry or a lack of full glandular tissue, you can't always tell by looking. So we always would want mom to try, but we sure have a clue that there's a problem here when we look at the damage to this nipple. And another, whether it's breast reduction or breast augmentation, these women need to have good lactation support so that we can watch to be sure their baby's gaining weight. This woman does not have an incision around the areola and maybe is going to be absolutely fine. It looks like that the nipple was not removed in the surgery, which is less common today than it was years ago. But again, we want to be on alert if this mother has any history of breast surgery for any reason, whether it is cancer, breast reduction, breast augmentation. Number three is adequate hormones and hormone receptors. So we'll talk just a little bit about that because we're going to do some fun stuff. There's two ways that lactation is regulated. One is endocrine, and that means hormones. And there's more than two hormones, but we'll just talk about two hormones. One is endocrine and one is autocrine. So we'll talk about endocrine first. So endocrine, the most common hormones, which I feel certain you're familiar with, are prolactin and oxytocin. So prolactin is a hormone released by the posterior pituitary. It's high during pregnancy, peaks at birth, and when the baby stimulates the nipple, the levels double, and it tells those milk-producing cells, which you could think of like as tiny muscles, to contract and to excrete the milk. And levels fluctuate. They're lower in the evenings, higher overnight and early morning. And you can't like just draw a prolactin level and know how well a woman will be able to produce milk. Because it's such um, it's a synthesis of multiple factors. So let's talk about oxytocin now, the love hormone. So this is released with nipple stimulation also, but it comes from the anterior pituitary, and it peaks at birth, and the excuse me, I misspoke. This is the one that tells those cells to contract. The prolactin tells the cells to make milk. So let me say that again because I misspoke. Prolactin tells those milk producing cells to make milk. Oxytocin tells those milk producing cells to squeeze, those myoepithelial cells, those muscle cells, to squeeze and send the milk out into the ducts and through the nipple and into the baby's mouth. And it's what we call the love hormone, and it's associated with feelings of affection and calmness and feeling like everything is okay. And this calming response can be inhibited by excessive stress, anxiety, pain, alcohol, and opiates. So the fourth one, and this is the one I think you're going to find the most important, is frequent, effective milk removal and stimulation of the breast. And this is the other mechanism of controlling milk, the autocrine. This is milk removal driven. So in other words, you could think, you got to remove milk to make milk. It doesn't matter how much oxytocin and prolactin you have circulating everywhere. If you don't remove milk, you won't continue to make milk. And that's a way of saying it that moms can understand. I've got to remove milk to make milk. And this is where we want to assess at the breast and looking at the nipple and breast before feeding, during the feeding, and again after the feeding. We want to think about latch, which we're going to talk about, positioning. We want to be able to help mom know her baby's swallowing, and again, looking at the nipple before and after the feeding. So if after the feeding, the nipple, can you see my lipstick?
Yes.
If the nipple looks like lipstick, do you see how it's not nice and rounded? The baby didn't have a good latch. So if I just look before the feeding or during the feeding, I won't catch the fact that the nipple was not, the baby did not have a good latch. And I won't know until after damage has occurred on the delicate nipple tissue. So let's think about that a little more. So this is just reminding us that how much milk a baby removes during the first 24 hours, the first day 1 and day 2, and up to 72 hours and up to 96 hours. And it's consistent with the visual aid I used of the different balls. So again, not expecting a newborn to eat like a 4-day-old. So let's talk about the infant's tools for breastfeeding. And before we move on to the infant tools, I want to pause for a minute because we're going to move into a slight variation on the topic. Are there any hot questions on what we've covered before we talk about the baby's tools for breastfeeding?
I'm going to bring up two that came up in the chat, I think is a good time to talk about them now. You were mentioning the different amounts that the babies would eat depending on their age, but someone had a question about the size of the baby. So for babies that are born at like somewhere in 8 to 9 pounds, do they require more than a baby born like somewhere in 6 to 7 pound range?
No,
Okay.
no, but a very small baby may not remove milk as effectively. And so milk may not be removed sufficiently to help mother make sufficient milk. So this is generic. This is just in general for all babies. That the quantity of colostrum that a mother makes is exactly matched to the quantity of milk a newborn needs. And so for the first 24 hours, 2 to 10 ml is typical per feeding, and an average of 5. Or as our shooter marble said, 5 to 7 ml. What was the other question?
Thank you. The other question is about, oh, here we go. If a baby didn't latch immediately after birth, is it normal for the baby to kind of play at the breast? So like, for example, licking, nibbling, coming on and off. Is that normal if they didn't latch immediately
Oh,
after birth?
that's a great question. First of all, most babies won't latch for an average of an hour after birth. So they will have skin to skin care for until the baby's breastfeeding reflexes awaken and the baby finds his way on his own and latches on to the breast by himself. So will all babies latch within an hour? No, some will take longer. And longer times to latch are linked to a lot of narcotics or opiates. So if fentanyl was used, a high dose of fentanyl was used as the epidural was put in, it might take longer to latch. And so we're not talking today about ways to fix breastfeeding problems, but I can tell you one generic way to fix breastfeeding problems, including a delayed latch, is lots of time spent skin to skin. So not only is skin to skin care preventative of breastfeeding problems, it fixes them. I hope that helped. We could do an entire talk on how to fix a variety of breastfeeding strategies for addressing a lot of problems, but skin to skin crosses all of them. So the most important thing, and how Baby Friendly defines it now, is offering skin to skin care for all mothers, regardless of how they plan to feed, all mothers, and for the breastfeeding mother, that baby stays skin to skin until the first latch, or until after the first feeding. And again, studies show it's an average of 1 hour before a baby latches. So that means some are going to do it faster, some are going to take longer. So we're going to move into the infant's tools for breastfeeding. And so the infant has 3 tools that helps the baby to breastfeed effectively: the infant's tongue, the infant's palate, the roof of his mouth, and the infant's jaw. And that's especially the lower jaw. The upper jaw is fairly stationary, and we'll talk about that last. So the baby's tongue actually does a movement that's called peristalsis. It milks the breast against the roof of the mouth. The front of the tongue stays over the lower gum line. So the tongue comes forward and remains forward and milks the nipple and areola tissue against the roof of the mouth. The middle and the back of the tongue rise up and drop like a wave in the ocean. And the tongue is what controls the pace of the feeding and the swallowing. So the tongue is one of the 3 tools of the baby to remove milk. The next is the baby's palate, the roof of the baby's mouth. So the breast is pressed up against the hard palate. So I'd like each of you right now to take your tongue and move your tongue against the roof of your mouth and back until you feel that it becomes soft. So the nipple, when the breast goes into the baby's mouth, extends all the way back to the soft palate. And as the tongue milks the breast, it compresses the areola tissue against the roof of the mouth and squirts the milk into the baby's throat to be swallowed. So if the nipple goes all the way back to the soft palate, or at least the juncture of the soft palate, there won't be any damage to the delicate tissues or pain to the nipple. And now we're going to talk about the baby's jaw. So the wide gape of the jaw, and that means a large angle of the jaw, is what's essential while the tongue is milking the breast. And this stimulates the milk ejection reflex and paces the feed. And so deep latch makes breastfeeding more comfortable. And what I want to do now, using some of these visual aids, which Martha, make sure that you guys can, that everyone can see, because I can't see myself. I want to show you what I mean by the baby's jaw. Let me show this next slide before I do this. So, so it's an asymmetric latch. The nipple lines up against, opposite the baby's nose, and the jaw and tongue drop, and the chin leads the way. So if the baby is coming up to the breast, can you all see my baby? I have a little larger baby here. Can you all see it?
Can you angle your camera just a little down? I think that would be helpful. Oh yeah, that's better when you back. That's better. Thank you.
Okay. So the baby's head tilts back, and he comes up and meets the breast with his chin, not his mouth. He meets the breast with his chin, and he comes up and over. And so let me illustrate that in a couple of ways. Imagine that I want to take a bite of this apple, and please tell me if I get out of good sync. So first thing before we take a bite of my apple is I want you to have your head straight ahead in line with your body, and I want you to open your mouth as wide as you can. Now I want you to tilt your head back and open your mouth as wide as you can. All right, which way? Head in line with your body or head tilted back allowed you to open your mouth wider? What did you experience? Did anyone put it in the chat, Martha?
We have 2 for tilted back and 1 for inline. A couple more coming in for tilted back.
Okay, so for those in line, I want you to try it again, because you can open your mouth wider when your head tilts back. So open your mouth as wide as you can with your head straight in alignment with your body. Now tilt your head back just a little bit. Now, let me know if that helped any. And I'm going to illustrate this with my apple here. Now, I'm turning sideways. Can you still see me?
Yes, we can see you.
Okay, so if I come at this apple and I'm going to open my mouth as wide as I can and take a bite, I'm not able to get a very big bite of my apple. But if I tilt my head back, reach my apple with my chin, and open wide, now I can get a bigger bite of my apple. I'm going to do the same thing with my hamburger. So can you guys see my hamburger?
We can see it, yes.
Okay, so if I line up my Big Mac, which I wouldn't eat because I don't eat Big Macs, but if I did, and I came straight forward, I don't think I can get a very big bite of this. But if I meet my hamburger with my chin and come up and over, I can get a much bigger bite of my hamburger. So we do this naturally when we eat a big sandwich. We would come below, open wide, and take a big bite. And I want you to start watching people eating their hamburgers. So if I'm the baby, I'm going to meet the breast with my chin and come up and over like that. So now I'm going to illustrate this, and I'm going to hope this works since I can't see myself. I'm going to pretend I'm the newborn and I'm going to latch onto a breast. Okay, so I'm going to put on some lipstick here. All right. Does that look okay? All right, so here's my breast. All right, am I lined up well for the video?
Yes, looks great.
All right, so now this time I'm not going to tilt my head back. I'm just going to come straight on. All right, so can you see?
Hey, Jeanette, we had a request which I think would be helpful. Could you take the slides down so your picture gets bigger so we can see it better?
Oh gosh, that's brilliant.
It is brilliant.
I actually meant to stop sharing. I'm so glad someone said that. And plus I can see myself. You guys are brilliant. Thank you. I meant to do that and I forgot. All right, so that's, oh, this is so helpful. Now I can see. All right, so there's as wide as I could get with my head in a neutral body alignment. So now, all right, so now I'm going to tilt my head back, meet my breast with my chin, and come up and over. All right, so I want to show you the difference. So this is a fun thing you can do in a prenatal class with moms too, where they have a really good visual. So give me a second here. And I don't ever hardly wear red lipstick. But let me show you this again too, because with my hamburger, again, I can come up and over and get a bigger bite than if I just come straight on. Or with my apple versus up and over. So it kind of makes sense. We do this naturally in real life, and that's why asymmetric latch is called the natural position or the instinctive position by Rebecca Glover. Is there anything you want to see? I'm so glad you reminded me to turn off my video my slides while I was doing that. Is there anything you want to see before I move on to the slides that I already showed you? Okay, so now I'm going to share my screen again. Oh yes, there's some amazing videos with good latch, and I can share some also. So, can you see my slides?
Yes.
So this is asymmetric latch. The nose is opposite the nipple. And what this picture illustrates is the chin right up tight against the underneath of the breast, and the you can see more of the areola at the top than at the bottom. And I don't know if any of you have ever seen these pictures by Rebecca Glover, but I just think they are a perfect illustration of meeting the breast with the chin and coming up and over. And she says you don't even have to worry about the nipple, because if you do it this way, the nipple will follow. So she says this is the contact spot where the where the chin hits the breast, well below the areola, and then watch what happens. And see how the nipple just follows? And now look at where the nipple is. It's way back at the juncture of the hard and the soft palate. The nostrils are clear. The tongue is over the lower gum line. And I thought you might like to see these one more time. So we'll just start again. You meet the breast with the chin. See how the tongue, the tongue remains extended below the gum line? It never retracts. And again, the nostrils are clear. The nipple is at the juncture of the hard and soft palate. And then if we go back to this first picture we started with, that's the exact picture, right? So, what questions do you have about latch before we talk about positioning?
We have a couple. One question, if you have, and maybe you can include in when we send out the resources, any pictures that you have of that we can use. Oh, there we go. Graphics that you can share where somebody with a large areola and a good latch, and then any other just like latch pictures in general, videos, resources, anything you've got.
Global health media. Have you ever heard of global health media? No. Okay, so those are free educational videos.
Okay.
And I will send you the link. And there are a myriad of videos that are, I use them when I teach in China, even though they're still in English, because the videos are so good. And there's two sets of every video. One is for the mother, and one is for the healthcare worker. And that's what I think is so amazing. You can show the mother the one for the mother, but there's one that teaches the healthcare worker. And they are on a variety of topics related to breastfeeding, newborn care, prenatal education. They're wonderful, wonderful videos. The company is out of Vermont. And the best part is that most of you or all of you speak English. So many of them are translated into Spanish if you have a Spanish population. A few of them are translated into Mandarin, not too many in Simple Chinese, but there are quite a few languages that are available. So that's why I love global health media.
Great. Thank you. I'll find the link and put it in the chat. And then we have a couple questions. about the picture that you showed. Is the mom guiding the baby's head, or does baby know what to do in that situation?
Well, the idea is to, let me move this down, is to, let me use my smaller baby. I can't, this baby's head won't tilt back, but the idea is we're not talking about early skin to skin, and we are going to talk about laid back nursing in a minute. Hi, I'm going to under here. But if we leave the baby skin to skin here and lean back and the baby's hungry, it's highly likely the baby will find his way to the breast, and we'll talk in a minute about laid back nursing. But it's absolutely, the older a baby gets, the more likely it is that your this baby here, her head tilts back. So it's the more likely it is that you're guiding, you're lining the baby up so that his chin meets the breast, and then pulling him towards you, as not smashing his face into the breast, but allowing the chin to reach the areola tissue, and then allowing the baby to come up and over. And it doesn't matter, it's the same technique no matter what position you use. And it's no matter what hold you use. So just making sure that the baby's chin is the first to meet the breast. So yes, you are guiding. But that is not to say the baby couldn't guide himself. And but most of the time, except in the early breastfeeding period where you're doing the initial skin to skin, you're guiding the baby. You're putting him in the position where he can use his instincts to attach to the breast, which is when he leans his head forward and his chin hits the breast. His chin hits the breast, he opens his mouth with the stimulation and up and over. Kind of like, I have this other visual aid here. This is a little breast right here, and in my little, the chin reaches the breast and up and over like that.
Great. Another question for you. Any tips for when the baby doesn't open wide?
If the baby doesn't open wide, then you won't have a good latch. So you just have to do it again. It's really important that mom knows that if it hurts at all, that she breaks the seal by inserting her finger gently in the corner of the baby's mouth and relatches again. And I'm going to refer back to skin, that skin to skin helps with difficult latch. So if you're having trouble with latching, and my rule of thumb is I wouldn't work with a mother more than 20 to 30 minutes. And if the baby hasn't latched during that time, I place the baby skin to skin and ask her to call me when the rooting starts again. Now, if you're doing a home visit, which I know many of you are, then you're probably going to want to work with the mother. But after about 30 minutes, the baby's probably going to be tired. But having the mother prepare in advance before you arrive. How many of you do home visits? Raise your hands. Home visits. So if you're seeing a mom and she's reporting difficult latch, you could have her prepare by holding the baby skin to skin, naked baby with just a diaper against mom's naked breast, warm blanket around the two of them while they're waiting for you to arrive. And maybe that baby will latch on by himself before you get there.
Thank you. Okay, one more for you in the chat. Any information about nipple shields? Anything that you want to share about that?
Well, I did not plan to present on the things like nipple shields and the variety of things that lactation consultants use. I'll just tell you generically, nipple shields are like a Band-Aid in most cases. It doesn't solve the problem. It only puts a Band-Aid on it. So it's hopefully someone using a nipple shield, and we can talk more about that at another time. But nipple shields, the risk of a nipple shield is that, and I actually have some, and I usually pull them out when we're talking about them. Nowadays, there's a little notch cut out so that the baby's nose gets closer to the breast. But the problem with nipple shields is it can often be hard to get the baby off. They have been associated with inadequate milk supply. And so while it's less likely with modern nipple shields compared to the old kind, which were essentially bottle nipples stuck on top of a breast, it's really better for someone that has expertise in lactation management to make a decision about nipple shields. On the other hand, sometimes a nipple shield, like say mom's damaged her nipples, and it won't solve the reason why the nipples got damaged. So if you don't fix that, you haven't done anything but put a Band-Aid on, and once the Band-Aid comes off, you're going to have the same problem. But sometimes a nipple shield might be used temporarily so to allow the sore breasts to heal. What I see most often, my rule of thumb is that if I have a good latch and on a damaged nipple, if I can count 30 to 60 seconds, if it's a good latch, the initial discomfort will subside. And so why do you think that is? Why do you think if a nipple is damaged and I have a good latch, after 30 to 60 seconds, the pain subsides somewhat?
The nipple is where it needs to be by the soft palate?
That's exactly right. So the nipple is way back, so you're not compressing the nipple against the hard palate, and so it's not being damaged. There's one more. Yep, baby will not be on the nipple. That's right, Michelle. Also, because the baby, a deeper latch, yep, Maria, and it's because the baby is swallowing. The baby is swallowing. So remember in the beginning of a breastfeeding session, it starts out suck, 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 and then the letdown. And remember, letdowns occur multiple times during a breastfeeding session. But as the baby sucks and letdowns begin to occur, it becomes less of suck, 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 and more of suck, swallow, suck, swallow, suck, swallow, and there's less negative tension on the breast. So a way to judge, do I need to relatch, is after a minute, if she's still going, ow, ow, that's probably not a good latch. And then the nipple can come out of the mouth and you can look and see if it's being pinched so that, if it looks like a lipstick tube when it comes out of the baby's mouth, it's not a good latch. And you want to relatch. You want to relatch. So let's look at positioning really quickly.
Sorry, I had a quick question about good latch.
Okay.
Hi, how are you?
Good.
Good. So there was a picture, it was a good latch, and the baby was on the breast, but the baby wasn't covering the whole of it wasn't covered. Yes, but is that still a good latch if the baby's not covering the whole?
Yes, very astute of you. So let me share my video again and go back to that picture. That's why it's called asymmetric latch, because more of the areola on the bottom is in the baby's mouth than on the top, because the baby met the breast with his chin and came up and over. Okay, so that was very astute of you. When I look at the breast, I should see the lower areola missing almost because I can't see it because the chin is there, and some of the areola at the higher portion visible. So let's look at that picture again, because that is exactly what you were supposed to see. That is exactly what you were supposed to see. So this is asymmetric latch. Let's go back one more. Asymmetric latch, asymmetric latch. Jaw and tongue drop, chin leads the way. More of the areola in the baby's mouth where it's closest to the chin than closest to the nose. So good, I'm glad you noticed that. So laid back nursing is much more. How many of you have heard the term? Tell me how many people are raising their hands, Martha. How many people have heard this term?
Looks like a couple, maybe half.
It's also called biological nursing or instinctive nursing and essentially, do you see how the baby's head is tilted back from this drawing? When the mom leans back like that, it's much easier for the baby to tilt his head back and latch on. And here's a picture of laid back nursing, except we can't see his chin very much. We just see moms in that position. If you don't mind, I'm going to go back to this picture. Let's see. I'm going to go back to this picture here because this self-attachment picture, with that one, can you see how the baby's chin, this shows how the baby's chin is at the breast and there's more of the areola in the baby's mouth at the bottom than on the top? And that's a self-attachment. So I'm glad Shayna asked that question. So let's see, I have to go back to here. And all right. So laid back nursing. And then this is really one of the easiest positions for moms to nurse in. And the reason, I just want to say that when I was a young mother, and I'm older than all of you, they told us that we needed to line the baby's mouth and insert the nipple right centered like this. There was no understanding of what babies did instinctively, and it makes you even wonder in the old days who was watching babies nurse, because that's not what babies did. Babies meet the breast with their chin and come up and over, but they would tell me I need to line the breast up and just center it and make sure that there's the same amount of areola in the baby's mouth at the top and at the bottom. And they also told me to sit up straight. And that makes it very, very difficult because now I've got gravity working against me. So if I'm sitting up straight like this, then the baby actually, the weight of the baby's on my arm. Whereas if I lean back like this, the weight of the baby is toward my chest, and the baby is much less likely, especially a very young baby, to lose his latch. So if we go back to the pictures, so can you see that picture?
Yes, we can see it.
Yeah. If we go here, he's much less likely to lose his latch because the weight of the baby is on the chest of the mama instead of the weight of the baby being on mom's arm and gravity working against me. So it really doesn't matter what position you use as long as there's a straight line between the ear and the shoulder and the hips, so that and when babies' arms are flexed and hips are flexed, babies have an easier time breastfeeding. So this shows great alignment with the ear. If you imagine a line from the ear to the shoulders to the hips, this is great alignment. And here's the baby at the side, or the football. Again, the straight line between the ears and the shoulders and the hips. And notice in this case that mom's got the weight of the baby's head in her hand, and she's clutching the baby tight against her chest. And let me stop sharing again. So if I am going to latch my baby on, I want to hug my baby's hips with my arm and then meet the breast with the baby's chin. And I am supporting the weight of the baby. If I use a pillow, the pillow is to support my arm. It's not to support the baby. And the reason is that if I have a baby on a pillow, as I move around, my baby will lose his latch. Whereas if I'm supporting the baby, I can breathe, I can look up as someone walks in the door. It doesn't matter what I do. My baby is staying with me because I'm supporting the baby on my chest and not putting my baby on a pillow. So always think the pillow is for the mom's arm. The pillow is not for the baby in the majority of cases. Do you see yourselves? Am I sharing?
We can just see the slides, not us.
There we go. And this is baby at the side. So let's talk for a minute about nutritive versus non-nutritive sucking. And babies nurse in a series of sucks with very few swallows in non-nutritive sucking. It's irregular and little milk transfer is taking place. So what we want is observable suck and swallow. And again, at the beginning, it'll be suck, suck. And then as the milk letdown occurs, it'll be suck, swallow, suck, swallow, suck, swallow. So nutritive sucking is slower, more rhythmical. The mouth is wider, and it may be 1 or 2 sucks per swallow or 1 suck per swallow. And this is where milk is actually being transferred. And you can teach moms to hear the audible swallow, which sounds like and what that really is it's the swallow part of the suck, swallow, breathe, suck, swallow, breathe. We already talked about this. So another way to tell that milk transfer is taking place, and remember that the mother needs to understand how to know that milk is being removed from her breast and that the baby is getting it. So we're talking about multiple ways of knowing that. And another way is looking to see if the baby's satiated. So look at these series of pictures from Barbara Wilson Clay in the Breastfeeding Atlas. Look at that baby's fist. It's tight, 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 tight. And look at the baby's frown. Do you see the baby's frowning? Now watch it during this breastfeeding session. Look how relaxed the baby's hands have gotten, and that frown is disappearing. Now look at the baby's hands and forehead. And now the baby has come off the breast satiated. So I'm going to show you those pictures again. So look at the beginning. Look at this hungry baby. And as the baby gets more milk, he becomes more relaxed and often can fall asleep. Another way for a mom to tell if the baby's getting enough milk is elimination. So the stools go from the meconium stool to the transitional stool to the breast milk stool. And on average, if the baby is removing sufficient milk, babies should have about 3 nice sized stools by day 3. 3, and some resources say 4 or more. So, but for sure by about day 5, you want to see those yellow, seedy stools. And babies should be pooping about a minimum of 3 times a day, a nice size stool if babies are getting enough milk. You can't tell from wet diapers. Babies will typically stool about 3 or 4 times a day, and for the first month. They may poop more, but at least that much. Another way to tell is by weight gain. And if you have a mom that's not sure her baby's getting enough milk, the best thing to do is have her get the baby weighed. Send her to the pediatrician's office or the nurse practitioner's office. And so on average, once the mature milk comes in at about day 4 or 5, maybe a little earlier for a second or third time mom, babies should gain an ounce a day, or that is the same as 30 ml per day for about the first month. And so that's a really neat way to see that the baby is really getting enough milk. Another way to help make sure mom is getting enough milk is to make sure she knows how to hand express. And we're not covering hand expression in this session today, but there are, this is my water breast, where you can, it's compress and squeeze in, compress and squeeze in. And let's see, a second, I'm going to escape. And stop sharing. So we could do a whole session on milk expression, but and this is a really tiny areola and nipple, I realize, but essentially you're squeezed together and press in, squeeze together, press in, squeeze together and press in. When no more milk comes out, you rotate the hand slightly, squeeze together, come in, squeeze together, push toward the chest wall. Moms will typically think they're like milking a teat of a cow and do it this way, but it's really squeeze together, push in, squeeze together, push in. So I think I only have a couple more slides. What time is it? Oh, 5:17, good. We have a little bit of time left. So I'm going to share my screen again. This is a pretty big breast and areola with a small baby, I think. I think you were asking about this. This is actually my daughter. And then the other thing is knowing when to give referrals. And this is a lactation consultant that is helping my daughter with breastfeeding. She had her son had to go to the NICU, and she had this wonderful lactation consultant help her who was amazing. So, and then making sure that that any supplement that a baby receives is always medically indicated. So, for example, syringe feeding, this would be an appropriate supplement for a baby that is 24 hours or less old. That's a TB syringe, so that's probably somewhere between 2 to maybe 3 ml to 4 ml. The baby doesn't need very much. But if a supplement is necessary for some reason, and in this case it was because the mother was not available to, the mother had lost consciousness, and so this baby needed to be supplemented. And fortunately, they had expressed some milk before she became sick. So there's an appropriate supplement with breast milk. So let's just take 6 minutes. I think we have time. I'm going to stop sharing. And what I'm going to ask you to do is, in your group of 3 to 4, talk about how you're going to apply what you learned today. Maybe just one thing you learned today that how you're going to apply it to your practice. So we'll just do small groups for 5 minutes, Martha, so that we have time to share a couple things.
Okay, sounds good. I'm making the rooms now. There you go. So you should see a timer when you get in there for 5 minutes. We'll call you back in. I think everybody is back. Looks like everybody's back now.
So I didn't tell you, and I should have, to have one person be the one to report out. If one person would take it on themselves to go ahead and put it in the chat, the summary of things that people are going to apply to their practice. But in the meantime, would a couple of you share with all of us what you're going to apply to your practice? We have 5 minutes left, and I think this is the time where we really need to know what we're going to use, what you're going to use, and we'll get ideas from that. So who would be willing? Or I could call on you. Who would be willing?
So I'll go.
Michelle?
We had some great ones. One of the ones that, one of my takeaway was, because I don't directly teach or involve with such education, I have a whole department for that. I would do the balloon and or apple demonstration. I think that will be easiest for me to get across. Also, I like the fact that you talked about when moms are complaining about the nipples being sore, that's because it should go away after a while. If babies latch properly, it will subside after a while. So those are my takeaways.
Thank you, Michelle. Somebody else.
I'll go ahead and go.
Thank you, Becky.
Sure. What we shared was that the nipple shield, what you shared about the nipple shield and how it's just a Band-Aid, and there's other underlying issues and ways that we can, not let the parent know that it's there as an aid. It's not there as a fix-all. It's not a forever tool. And that was something that one of the other girls in our group shared. And I think it's a really good one because a lot of parents will decide that, once it's on there, they're like, this is how I have to do it every single time. And that's the only way that they can do it. And, to help to teach them like, hey, well, let's try to fix things before you make it an everyday, every latch thing, especially if there's no nipple damage happening, then let's try to latch the baby without and get you the help that you need.
Thank you, Becky. And anything I would say is never carved in stone. There's exceptions to everything. If the only way a mother would continue breastfeeding is if she was going to give up if we didn't try the nipple shield, of course we would try the nipple shield, So, nothing is carved in stone, but we have to remember it very seldom fixes the issue, the underlying issue. I'm reading some great things in the chat. We have time maybe for one more person to share.
I can share.
Thanks, Maria.
One of the things that we covered in our group was, many times babies won't open wide, to get the baby latched on. And one of the techniques that I've used is, we tell mommies to rub their nipple on baby's nose to chin, and that helps with, getting a wider mouthful. But today you covered a different technique, which, I'm interested in implementing that, as HLs is, you said baby's chin to breast, and then the baby goes up and over for a deeper latch. And then I know someone mentioned the areola, and so it's not visible because they're already touching the chin at the bottom. So we're hoping to implement that in our next engagements, rather than doing the nipple nose to chin for opening, and we'll see how that comes out. Also, I like the fact that you talked about if the baby can't self-regulate and the baby just cries and cries, introducing the skin to skin, and maybe letting the nurse know, or the lactation consultant, we attempted to do a latch, baby wasn't ready, baby's actually self-regulating and doing the skin to skin. That's important. And then also, I know you did a reflective question, like what gets in the way of breastfeeding? That's a good starter point, because now we know where mom's at in terms of she wants to breastfeed, but now she's thinking of all the obstacles that can happen, during the hospital stay and then once she gets discharged.
Thank you. Well, thank you all. I just had so much fun with you this afternoon. Thank you for inviting me, and I'm so honored that you took the time to be with me. And it's just been great. Martha, Amy, Vanessa.
Thank you. This has been so great. I think we were really happy to have you once again and just be able to hear all of your knowledge. You have so much to share. So before, I know everybody, we're a minute over here, but let's give Jeanette a big round of applause. Thank you for being with us, for preparing this webinar, for talking through all of this with us, answering every question that everybody asked. We really, really appreciate it. So thank you so much for your time.
Oh, thank you all, and enjoy the rest of your day, and I hope to see you again.
Great. Yeah, we hope to see you again as well. And if anybody has questions, you can email me. I'll be sending out the recording, the slides, any resources in the next couple of days. So be on the lookout for that. The recording probably not till next week, but I'll send it out. And in the meantime, if you have questions, you can email me, and we'll get you in touch with Jeanette too if you have direct questions for her. Thanks, everybody.
Bye, everyone.
Bye. Thank you again.